So we come to the final module today from Australia. When we first thought about it, you were the person I thought about, Georgina, because I wanted to say our next speaker is speaking from tomorrow, right? So you're already in tomorrow morning, right?
Correct. It's Sunday morning here in Sydney, Australia. Thanks for having me, Neil.
Great to see you, Georgina. So we asked you to review some of the data related to neoadjuvant and adjuvant therapy in melanoma. So many new things going on. But I've got to ask you about something first. We actually brought up, believe it or not, this morning at our lung cancer session. I'm just curious what your thoughts were about it, which is a paper that was presented at the recent ESMO meeting in Paris just a few weeks ago. This is from the Columbus trial, looking actually at encorafenib and binimetinib in BRAF mutant metastatic melanoma, one of the alternatives that's now, standard of care. But the thing that struck me about this, and we asked the lung people, have you looked at your patients with EGFR, et cetera, for this? And apparently they haven't, so I'd be real curious to know. But you tell me, what does this mean, the fact that in targeted therapy, people who have high PD-1 levels get more benefit and high TMB?
So this is not new. We've actually seen this for many years now in melanoma. It's actually prognostic. So, but here we see something different, which I'll explain in a minute. So we know that people with a high tumor mutation burden, high PD-L1 expression in melanoma, it may not be the same in lung. Lung and melanoma are very different tumors. In melanoma, we see a lot of T cells in that sense, and we know that high T cells is prognostic in melanoma. Even if we had no drug therapies available, when you have a primary melanoma with lots of T cells, high PD-L1, high tumor mutation burden, those tumors have a better prognosis without drug therapy. Add in drug therapy, we're seeing this across the board, whether you treat with an immunotherapy like a PD-1 inhibitor or a targeted therapy, the patients do better with that drug therapy. Now, what was really interesting about the data you've just got here is that you see the greater benefit when you add the MEK inhibitor as well in PD-L1 low patients. It's only slight, but you can see it on the left there. But yeah, in general, it is associated with a really good prognosis. So the other thing is we just don't know the difference with lung and melanoma. Melanoma has a much more heightened tumor microenvironment and much more talk between the tumor and the microenvironment than we see with lung. And PD-L1 expression is not constitutive in melanoma, meaning PD-L1 expression is due to the fact we have lots of T cells there and lots of interferon gamma. It's not driven by any other mechanism.
Does targeted therapy, does BRAF MEK work better in patients with high PD-1 levels?
I wouldn't look at just high PD-L1. I would be looking at interferon gamma and tumor mutation burden together. So there was data from COMBI-AD, which we'll get to in a minute, which was an adjuvant trial of dabrafenib, trametinib, another BRAF MEK combination. And we saw, again, the greatest survival or recurrence-free survival in the early stage 3. The best performers were those who had a high interferon gamma, high tumor mutation burden.
So we asked you to review your work and others in the adjuvant and particularly the neoadjuvant setting. I'm really curious to hear about that. Could you please review the data?
Excellent. Thank you. So I've got the clicker here. Is that advancing? Great.
Yeah, you got it.
I only have 6 minutes, so I'm going to really race to the data slides. I think that's the most important. But before I do that, really importantly, let's just summarize the difference between adjuvant and neoadjuvant. At the top there, you can see the adjuvant therapy. We take early stage melanoma, resect all melanoma we can see. Now, I have someone there with the lymph node, so it's stage 3, but we now know that resected high-risk stage 2B and 2C melanoma adjuvant therapy is very effective. We then treat for 12 months, and the idea is that we are mopping up any undetectable micrometastatic disease we cannot see on scans, and we improve the relapse-free survival, and I'll talk you through that data in a minute. Neoadjuvant, it's very different. we treat earlier with drug therapy for 6 weeks as per the International Neoadjuvant Melanoma Consortium. And then we resect after 6 weeks, and we categorize the pathological response as either complete, meaning no tumor cells, so 0% tumor cells, as I've written there, near complete, that's less than or equal to 10% tumor cells, partial pathological response is between 10 and 50% tumor cells remaining, and no pathological response is more than 50% of tumor cells remaining. So what I'm going to outline first is just the data on the adjuvant therapy, and then I'll move to the exciting area of neoadjuvant therapy. We've been now using neoadjuvant therapy in clinical trials for many years, about 7 years actually, and we have a lot of data which I think will cross over to other cancers. I know you mentioned earlier, Neil, about the GI neoadjuvant therapy, and indeed in melanoma, we have proven that having some tumor on board in the neoadjuvant early stage setting does improve the efficacy of immunotherapy. So adjuvant therapy. There are 3 major classes of drugs or papers that came out in 2017, 2018, adjuvant dabrafenib and trametinib, BRAF and MEK for resected stage 3 melanoma, nivolumab for resected stage 3 and 4, and pembrolizumab for resected stage 3. All 3 of those papers basically showing that 12 months of treatment, and 12 months is empiric, after complete resection, reduce the risk of recurrence by approximately 50%. Shown here is a table, and I hope the animation works, but I just wanted to show you how many trials and how much data there is now for melanoma. First of all, stage 2B and C resected, 2 major trials, Keynote 716 of pembrolizumab versus placebo, Checkmate 76K, nivolumab versus placebo, and the hazard ratio is 0.65 for pembrolizumab, 0.42 for nivolumab. I don't believe there is a major difference in these drugs. The confidence intervals cross, but both drugs are effective in preventing recurrence in resected stage 2B and C. And we have seen also the distant metastasis-free survival benefit, 0.64 hazard ratio, 0.47. So in other words, we're talking about a 50% reduction or 35% reduction in the risk of recurrence or distant metastases with both these drugs. So the next slide, underneath that slide, I don't know if it shows, but I had all the trials for stage 3B, 3A, right up to 3D, and stage 4 resected melanoma, again showing a reduction in the risk of recurrence by around 50%. And there has been one trial of purely just stage 4 melanoma, and that showed a massive reduction compared to placebo of ipilimumab combined with nivolumab at our normal advanced stage dosing, and that showed a huge benefit in terms of preventing recurrence and also improving overall survival. So what do you do when you have a BRAF mutant patient with early stage melanoma, stage 3? We don't really have any head-to-head data, but what I can show you from the 2 trials, Combi-AD of dabrafenib and trametinib versus placebo, and the Keynote 054 pembrolizumab versus placebo. And what you'll see is on the right there, I have just the BRAF mutation positive patients from the Keynote 054 trial. So I'm comparing apples with apples here, and we can see a very similar hazard ratio of 0.51, either dab-tram or pembrolizumab versus placebo. However, there is a difference. The 3-year landmarks are pretty similar. I've got a circle over them there. However, the curves come together and then become parallel for Combi-AD on the left. However, the curves seem to be separating more with time for anti-PD-1 therapy. And we take our biases from stage 4, and we know in stage 4 we prefer to use immunotherapy up front, and we suspect we'll see much higher landmarks in time in the adjuvant setting. So now let's move to neoadjuvant therapy. First of all, the platform. We're very organized in melanoma. We've now been doing trials for over 7 years in this setting. We have an international neoadjuvant melanoma consortium, and we've come together to fine-tune exactly what we do across the world. So stage 3, resectable melanoma, resist measurable, biopsy at baseline, biopsy on treatment, important for translational research, and then a therapeutic dissection of all lymph nodes at week 6. Some trials we do or do not use adjuvant therapy, and our primary primary endpoint is pathological response, and our secondary is relapse-free survival. So if we now look at the, this is just the INMC. I'm going to skip through this because I want to get to the data, but we're very organized. These are white papers we've published on how to do the trials, pathological assessment, surgical endpoints. But importantly, this pooled analysis from all our trials, I think this is really what summarizes it beautifully. On the left, we have our immunotherapy. And with PD-1 single agent, complete path response 20%. For combo, ipi-nivo, 43% complete path. But in immunotherapy, any pathological response, whether it be partial, near complete, or complete, do very well. Look at these relapse-free survivals. There's hardly any recurrences. And 75% of patients who get ipi-nivo have a pathological response. Targeted therapy is very different. Yes, we see that complete path response is associated with a much better relapse-free survival, but you still can recur. We don't see this much with immunotherapy, even for a partial pathological response. So that's a summary of all the data to date. I just want to highlight the other fantastic things about neoadjuvant therapy, the 5 advantages. First of all, as mentioned in the GI session, we actually have proof that just simply giving drug first before surgery gives you a much better and longer durable immune response. Secondly, patients love the feedback. They find out at 6 weeks whether they're a responder or not. 75% are if you give them dual treatment with immunotherapy. And so patients can then go away saying, hey, I've only got a less than 5% of recurrence rather than 70% risk of recurrence, which is what you feel when you have adjuvant therapy. We can then tailor surveillance. So here I've shown you with the non-responders or partial responders, we add adjuvant therapy and we do scans for the first 2 years every 3 months. And then we start increasing the time between surveillance. But with major pathological response, we can go straight to 6 monthly scans and we give less surgery. We now do index node, not therapeutic lymph node dissection, and we don't give adjuvant therapy. I've got in boxes here all the trials we've done to show that this is how you can de-escalate surveillance and treatment. Lastly, or fourthly, I should say, it's a great translational platform and we collect a lot of tissue. This is a patient who did not have a pathological response. And so, in fact, we're now using biomarkers to select either single agent PD-1 or dual therapy. It's a great platform for rapid drug development. We've now benchmarked all these drug therapies. Just a warning, be careful of intralesional therapy. You cannot say that the complete pathological response rate correlates as well as relapse-free survival as we see with intravenous immunotherapy. It is not the same for intralesional at all. And then this is really important, and this is the SWOG 1801 trial. Beautiful, simple trial. Adjuvant arm versus neoadjuvant. The only difference, both arms get 18 cycles of pembrolizumab. The only difference is 3 cycles of pembrolizumab occur before the surgery. And what a difference simply doing that can make. The new standard of care is over the top of it, but if you can see the red curve, it drops right down and we have a hazard ratio of 0.58. That's a more than 40% reduction in the risk of recurrence simply by giving the immunotherapy up first. We've actually shown that what you do is you get a better T-cell memory and expansion of existing T-cell clones by giving the treatment up front. So you do improve the immunity simply by giving the same treatment when you have a little bit of tumor on board. We're doing a phase 3 trial of ipi-nivo neoadjuvantly, that's arm A, versus our standard therapeutic lymph node dissection and then adjuvant nivolumab. And we should have those results in 2023. So with that, the next steps is every pathological department needs to know how to do neoadjuvant pathological assessment. Melanoma has been leading the way, and we need to internationally implement those guidelines. They have been published. We're now doing biomarker-selected neoadjuvant trials, so de-escalating only to anti-PD-1 for those with high interferon gamma at baseline. And we've started a trial, believe it or not, in stage 2 neoadjuvant therapy. So with that, I hope that I've summarized the data for efficacy. Adjuvant therapy is efficacious, but neoadjuvant therapy seems to be more efficacious simply by giving the same drugs earlier. And we've got a bit more work to do to educate the world about how to get on with neoadjuvant therapy. I'd like to thank, it's back to the front, but thank all of those involved with all of this research to change clinical outcomes for melanoma patients.
So, Georgina, first of all, I never noticed that logo with the umbrella there. I love it. Really cool. Like it a lot. So I guess one question about neoadjuvant is why? Do we have data or any hypotheses of why just bringing in neoadjuvant therapy, you see better outcomes?
The hypotheses at this stage, now we definitely have translational data that proves you do get a better immune response. So I haven't shown the data in the interest of time, but given neoadjuvantly, we see the T cell clones that are existing. They're there. They've recognized the tumor, but they just can't eat up the tumor. Those clones expand much more significantly in a short period of time by giving treatment neoadjuvantly. And what we think's happening is that the tumor the immune system can see its enemy a little better when you have higher tumor volume. We also wonder whether there's something about the lymph node involvement and the expansion and recognition at the lymph node where the T cells get selected and expanded is better when you have a little bit of tumor on board, particularly in the lymph nodes. So there are our hypotheses that you just need that right volume of tumor for the immune system to mount an excellent response. Now, interestingly, Neil, the hazard ratios we see with immunotherapy in adjuvant are as what we see in the metastatic setting. So we're seeing a consistent, we're not actually seeing a drop in efficacy in the metastatic setting, which is one of the theories. People say, oh, your immune system's less active in the metastatic setting. But I guess we're picking up melanoma quite early now. We scan a lot. And so we're seeing just as much advantage of immunotherapy in the metastatic setting as we do in the adjuvant. And it seems to be a sweet spot. Neoadjuvant is a nice sweet spot where you have enough tumor for the immune system to really see its enemy and train itself.
So
whereas you don't have that same volume in adjuvant where you've resected most of the tumor.
A couple other final points. One, in terms of, you're out there in the future, but in terms of adjuvant therapy today in the BRAF positive patient, obviously you have two alternatives. Curious for practical purposes, I'm sure most of your patients go on trial, but outside of trial, how do you make that decision? One of the issues with immunotherapy is some of these people are cured. You may be inducing, lifelong diabetes, et cetera. BRAF can be challenging, but you don't see those kind of issues. For practical purposes, outside of trial, how do you make that decision?
Okay, first and foremost, it's a discussion with the patient. Everybody is different. Everybody has a different risk appetite, and it's contextualizing those toxicities. With patients with less risk of recurrence, 3A melanoma, the idea of irreversible toxicities, particularly the endocrinopathies we see with anti-PD-1, become more of a discussion and a problem. In general, though, we tend to use anti-PD-1 first, but it's a discussion with the patient. There are some populations who cannot have anti-PD-1 for various reasons, rheumatoid arthritis. We'd rather wait until they get metastatic disease to even try immune therapy. However, in those cases, you can happily give BRAF and MEK together as an adjuvant therapy. So it's a discussion with the patient. The risk of recurrence, the higher the risk, the greater the appetite for irreversible toxicities. And I have to say, Neil, in the scheme of things, 8 in 1,000 type 1 diabetes is pretty low risk, really. And thyroid, which is the common one, is very easily managed. And we have to remember 10 to 15% of Northern Europeans get thyroid abnormalities that are non-thyroxine anyway. So it's got to be practical as well about these irreversible toxicities. Weighing that up against dab-tram, which can be quite tricky to get patients through the year of treatment, it really can. And they're on and off, and they're constantly ringing our nurses, and every clinic visit initially in their first 3 months can be quite difficult. However, they don't have the irreversible toxicity.
So yeah, the idea of talking to the patient makes a lot of sense. One more, so many other things. We have a lot of them in the slides for people to check out. But we, as you can imagine, in our renal session, we talked a lot about anti-angiogenics plus AI, and I see that you all are starting to look at that. Just kind of curious what you think about this strategy of IO plus anti-angiogenic. I see we have some data here looking at lenvatinib Pembro.
Yeah, really interesting, compelling data, particularly in this phase 2 LEAP 004. These patients were really resistant, selected out. Many of them had progressed on Ipi-Nivo, so combination. There is a place for this treatment. It's selecting who those patients are. Long term, there aren't many. So here we see the response rate. This is a very, very resistant population, and these are true responses. And this is blinded independent review. So there is a place for this treatment. It's hard going, giving lenvatinib. It has those low-grade, constant toxicities, but there is a place for it. What we are working on now is trying to select out who those beneficiaries are. About 10% of these patients all up, not all responders, but 10% have durable long-term control. And we've been able to stop the treatment at 2 years completely. Who are they? I think we're going to move to a world where we will be able to select out who just needs PD-1, high interferon gamma, high tumor mutation burden, who needs a combination CTLA-4 anti-PD-1, and then who does not respond to that doublet. And that's where we're heading.
So, Georgina, thank you so much for joining us today. Audience, thank you for spending the day with us. We look forward to seeing you next year. Have a great day.